My talk is femoral implant selection in complex primary hips. The aims of, everyone knows the aims of a hip replacement is to get the right height of the patient, restore the offsets vertical and horizontal, get the right version and increase your head size. What material to be used for your primary femoral component has to be always titanium. If you see the modulus of elasticity of cortical and trabecular bone, the nearest material available is titanium. Cobalt, chrome and stainless steel are way too higher, and that will lead to a lot of stress shielding and loss of bone over a period of time. Different type of coatings are available. You have to choose which coating you use. So what are the points that we anticipate in a complex primary hips? We are anticipating a femoral deficiency, short stature, poor bone quality, shortening and high riding hip centers. So what are the designs that you are probably looking at? We have 6 type of designs, type 1 to type 6. Normally in complex primary hips, you will be going in for a type 3, either type 3A, B or type 5 stems, where type 5 stems are fantastic stems, modular, where you can dial your sleeves to get the right version as far as the proximal portion is concerned, and you can dial your distal femur into a different portion, and that distal femoral canal is going to give you the correct version, and you still get a fantastic fixation. That is particularly in cases where you are dealing with a DDH, where majority of the times the neck is in retroversion and your normal uncemented stem is going to give you a bad retroverted hip. So let's start looking at these x-rays. This is a case of a coxa valga with a big magna head. So there are higher neck shaft angle, large head is available. So what you have to do is you have to keep a stem which is a bit protruding than your normal or usual anatomy that you will put. Try and get that leg as much as down so that you increase the leg length, but do not try and get it perfectly matched unless it is easily possible. Otherwise there are very high chances of injuring the sciatic or having a palsy later on. Developmental dysplasia is one of the major complex primaries that we operate, and I enjoy using these developmental dysplasias. A small tip for everyone is, if you are dealing with a developmental dysplasia, make sure that you have done CT scan of every single patient. It is not just to see the acetabular anatomy or femoral anatomy, it is basically for measurements. These developmental dysplasia patients will have short stature, their acetabulums are very small, and surprisingly their medullary canals are also very small. So you have to know the diameter of the medullary canal that you are going to deal with. Also you have to know the acetabular size that you are going to deal with. Inherently these hips are very unstable, so you have to make sure that your versions are correct, your lengths are correct, and you repair your capsules really tightly well. Otherwise the chances of dislocation are very high. So this is a case where you are having a developmental dysplasia on both the sides. On the left you are having a wandering acetabulum with the head availability. Fortunately, because I could use this head to reconstruct my acetabulum and get my acetabulum into correct place. On the other side, the head is completely resolved with a high riding hip center. The LT is almost at the level of teardrop or even above the teardrop. So what do you do in these cases? Bilateral cases, you can aim for the perfect hip center, reconstruct the acetabulum on the other side, and use a direct stem or normal stem that goes in. Now a tip is, here I have used a normal stem, but this looks like a normal stem, but this is called as a DDH stem, which comes as a separate stem. Normally they will not keep majority of these companies these DDH stems, that is called as size 6 stem, which is a very short stem. The important part is these short stems do not take a lot of weight, so make sure that you have weighed your patient well before you take in them for surgery. If the weight is more than 60 kilograms, do not use a DDH stem. The DDH stem is likely to break over a period of time because of loading, and so if you are dealing with a DDH, make sure that you have you weigh the patient preoperatively. Now the real problem comes if you are dealing with a unilateral DDH, because now the hip centers are going to be different. The one which is normal is at a normal level, and the DDH stem, usually the DDH side, usually the hip center is very high riding. So that's the x-ray where you get a high riding hip center, only one side. This is a 60-year-old gentleman. He was walking on this for a very long time, and he has developed so much of contractures. So what do you do in these cases is do a subtrochanteric shortening osteotomy. Try and get your head at the center if possible with a shortening osteotomy. Do not put in your final implants before you have done the complete trialing. Once you have done the complete trialing, then only put in a final implant. This is a cerclage wire that I always put before I do put my final sleeve of SROM, because the final sleeve of SROM, it is very likely that you will just shatter open the proximal femur. So you protect your proximal femur by putting in a good cerclage wire so that you protect your proximal femur, and then you have an independent fixation in the proximal area and a good fitting stem in the distal area. I agree that the stem is a bit too long compared to what I would have probably liked, but that's my post-operative thought. On table, it was a fantastic fixation with a absolutely stable osteotomy here. Now the problem with these modular stems is availability of sleeves is going to be an issue. There is lot of problem that we are not getting good sleeves available. Second is the cost. They are very expensive, so majority of the patients may not afford it. So what is the other trick is use any conical stem and put in a derotation plate if you want. The other option is, do you do a step cut osteotomy of the subtrochanteric area where you get an inherently stable osteotomy, but a regular osteotomy with derotation plate will also be good. Again, a case of DDH, a unilateral case where the hip centers actually are at the same level. Here now it's a very interesting case. Here we have used implants from 3 different companies. Now that's the post-op X-ray. That's unfortunately this cup is no more available. This is a Mallory head cup which was available by Biomet. So that Mallory head had 4 fins on the periphery where you get fantastic fixation intraoperatively, additional screw use of head to reconstruct the whatever superior dome defect that was there. Again, a DDH type of a stem. Usually if you say a fully grown head here, the chances that you are going to get your hip down and you will have a nice abductor are very high. Those patients who have a resorbed head or a very small head, the chances that you will need a subtrochanteric osteotomy are very high. My threshold for doing a subtrochanteric osteotomy in DDH is very low. If I'm struggling to get my hip down, I don't mind doing a subtrochanteric osteotomy and going in for a modular stem. So as I said, you have to weigh the patient before operative. If DDH cases, if they are less than 60 kilograms of weight, you can go for a DDH stem. If they are more than 60 kilograms, try and stay away from your DDH stems because they will break. Proximal fitting stems are better for osseointegration. Modular stems, if you are going for a subtrochanteric osteotomy, if modular stem is not possible because of cost or other constraints, then probably a conical stem with a right implant would be a choice, if required with a derotation plate. Fused hips, as we were discussing earlier, fused hips is again a good case, complex case to turn down to. Problem is, it is very difficult to find out the rotation intraoperatively. It is very difficult to find out the depth of the acetabulum intraoperatively. I don't mind using a C-arm every single time when I'm turning down a fused hip. It is not a shame to use C-arm. Use technology to your advantage. Put C-arm images in and measure your acetabulum so that you can know where is the center of the acetabulum and where are you going to, how much depth you are going to go. So that's just a X-ray where we have done a bilateral simultaneous. This patient was fused with complete fusion of the spine. We had to do a nasal intubation and then we had to turn both the hips at the same time. One very interesting case, a rare deformity in DDH in fused hip is abduction deformity. Usually in majority of your fused hips, they will be in neutral or bit of in adduction. Now this is a patient where you have an abduction deformity, external rotation deformity in both the legs. This is how he shows after anesthesia with almost a 40 degrees of flexion deformity and abduction deformity like this. Now if you identify, we have put some towels underneath so that I can manage the abduction deformity on the other side, otherwise I will break that abduction deformity on the opposite side. And then we turn down and put a new hip. Here is again my own failure, or I should say is on the right side, we went in too deep inside the acetabulum before we could realize, because these bones are very, very, very soft, and before you realize you are going deep inside the acetabulum. So we utilized the experience on this side to get our acetabulums to a better level on the other side. So in these cases, again, the femoral side, you can go in for any stem that you want. Majority of the time, type 3A or type 3 stems will be sufficient. Unstable proximal femoral fractures, metaphyseal fractures with loss of metaphyseal bone osteoporosis, and a very wide medullary canal, which is a capacious canal. This is a classical X-ray of a shattered trochanter with a basicervical neck femur fracture with a lesser trochanter and greater trochanter a separate piece. Some trauma surgeons would probably say that I can still fix it, but I have revised ample of failures of fixation, so it is better to go and do a bipolar or a total hip replacement. In these cases, again, using a type 3B stem is the choice. Cemented can be used, but then it becomes a problem for healing of your trochanters. So using an uncemented type B conical stems is the choice. Failed fixations like avian post neck femur fractures or IT fractures, again, you have to make sure that you pass at least 4 centimeters below the last screw, so that you don't get a fracture at the last screw. Similarly, you have a big fixation here where you are going to get a longer stem, which is required. Again, using a cemented stem in these cases is a big no-no, because the cement is going to come out through those holes, and then it is going to be a problem. And the last case that really is very important is this case, where you can see that your medullary canal is really very thin, and then putting in any stem in this is very difficult. So what you have to do is read your x-rays well, keep the armamentarium open, have a high speed diamond burr available on table, keep your reamers available on table. Don't mind putting in the guide wire and ream the medullary canal if required, or a diamond burr to increase your canal. And then a short conical stem, which is again a type 3B, is a fantastic stem in this. This is a Wagner cone that we have put in a primary with a dual mobility cup on the top. So the take home message is thorough clinical examination is the most important part. Always weigh your patients if you are dealing with DDH, if you are planning to use a type 6 stem. Read your x-rays very well. Keep correct or contingency implant. So if I am doing any complex primary, I will always have a 3B stem available on table. Majority of the times I will be able to get away with a regular stem, but I will always have a long stem available on table. I will always have a better acetabular cup available on table. Particular instruments like high speed burrs or cannulated reamers and broken screw removal sets have to be kept ready if you are dealing with a short or a very thin narrow medullary canal or with a failed implant. With that, I thank you, and if you have any questions, I'm open for questions.